Hello, doctors. Please, can you see me? Can you see me? Those joining us on Zoom, can you see me? If you can see me, just type yes, yes, yes. Because we are about to start, and it looks like the class is almost full already. So please, if you can see me, just type yes, 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 yes. And please, when you come in, kindly mute yourself, okay? Because we have friends who are joining us on Facebook and YouTube, so we don't disturb them. So please, if you're joining us, kindly mute yourself. All right, kindly mute yourself. If you're joining us, kindly mute yourself, and we get the game going. Hope everyone is doing well, and hope you are enjoying your Thanksgiving. Um, yeah. Okay, beautiful. So it looks like you see me. And those who are joining us on YouTube as well and Facebook, please, can you type yes, yes, yes? Can you type yes so that I know that you are joining us and you are seeing us? I really want to make sure if you are joining us on YouTube as well, just type yes. If you're joining us on Facebook, type yes and let me know exactly where you are joining us from. Don't worry, share the link with your friends, as many as possible. Because we have people join us on Zoom, Facebook, YouTube, everywhere. So I really want to make sure that you see it. And then those on YouTube and Facebook as well. Do you see my slides? I want to make sure that you see the slides because as soon as we start, it's tough for me to go back and make all those changes. So I just want to make sure. Do you see my slides? Those on YouTube and Facebook. Okay, beautiful. It looks like I can see what is happening on YouTube as well. So doctors, we are about to take off. Thank you very much for joining us today. As usual, I tell you, please, if you come in and you are not talking, kindly mute yourself so that the class can go on. Awesome. So today we're going to dive into approach the fussing baby, to the fussy baby and the crying baby. Okay, approach the crying baby and the fussy baby. So let's get in right away. Like we do, we're going to start with the objective, the rationale, the main objective, the enabling objective, and then we go through the enabling objectives one by one. So the rationale for this particular topic is although it is common for children to cry or fuss, and this is what I always say. Remember that we've met this word over and over and over again, and I'm going to highlight it. Common. The exam is testing your common knowledge. Common things are common. So if we come to abdominal pain, you say, oh, even the abdominal pain is common. Now we come to crying and fussing baby. It also says the same thing. Although it is common for children to cry or fuss, it is important to distinguish between benign and organic causes of crying and of fussing in a child. So that is something you want to start with. As soon as you start studying, make sure you know how to tell this cry from this child. Is it because the child has an organic cause or is it because the child has a benign cause? Now, it goes on to say the place is a bit warm. So I'm going to take off my sweater. It goes on to say that, you know what? The causes of crying and fussing in a child can be functional, for example, hunger, irritability, lack of sleep, or colic. All right. And it can also be due to trauma. So, like injury, which can be physical injury, emotional abuse, or even trauma from, parents to the child. It could also be from an illness. Now, it says that given a crying or a fussing child, the candidate will diagnose the cause, the severity, and complications of the underlying issue, and will initiate an appropriate management plan. In particular, the candidate will differentiate pediatric emergencies from conditions which require non-urgent treatment or reassurance. Okay, and I'm going to record the session so that you can all have access to it as well. Where's my record? Where's my record button? Okay, good. So I record. Please, can you see my screen? Those on Zoom, can you see my screen? I want to make sure. It looks like those on YouTube can see it, and those on Facebook, but I don't know whether you can see my screen on Zoom. Can you see it? If you can see, just let me know. Okay, good, good. So I'll just continue then. So the key objective to the approach to, the fussing and crying child is, given a crying or fussing child, the candidate will diagnose the cause, the severity, the complications of the underlying issue, and will initiate an appropriate management plan. Okay. In particular, the candidate will differentiate pediatric emergencies from conditions requiring non-urgent treatment or reassurance. Okay. Um, and then we move on to the enabling objectives. So, given a child who is crying or fussing, the candidate will, number one, list and interpret critical clinical findings, including those findings which are derived from, number one, a history of the child's previous behavior, the child's sleep pattern, oral intake, associated symptoms, the child's social circumstances, and then a full examination aimed at determining whether the child is sick. Okay, so whenever you are dealing with, you know, a child is brought into the clinic crying, a child is brought into the ER crying. If you are dealing with such cases in your MCCQE1 exam, make sure that you know the physical exams you need to do. Make sure you know the kind of history you're going to take on these children. And then another enabling objective is list and interpret critical investigations, including investigations for any suspected underlying disease or trauma. So if a child has gone through, any form of traumatic experience, you must be able to list the interpretation for investigations you're going to do for that child and construct an effective initial management plan, including counseling caregivers if the fussy or crying child does not have an organic disease. So, because it's not every child who is crying who has an organic disease. So, there are some of the situations where your management plan should be reassuring the parents. Okay. There are some of the situations where your management plan should be just reassuring the parents of that particular child. All right. That should be your management plan in some situations. And then determining if the child requires follow-up for additional investigation and management. And determining if the child needs a referral, either immediate or elective, and ensuring the child's safety if abuse is suspected. So what I did was that I took my time and broke the concepts down so that you can see the exact topics you need to cover. So if you pick this particular objective, what are the topics you really, 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 really need to cover? What are the topics? Number one, you must be able to distinguish between benign and organic causes of a crying and fussing child. Number two, you must master, if you are asked, how does hunger present in a child? You must know. How does irritability present in a child? You must know. How does a child who lacks sleep, how will that child present? You must know. How will a child who presents with colic? You must know. How will a child who presents with physical injuries? Where are the areas a child with physical injuries, how will it present? And you must even know, for various age groups, the kind of physical injury they are prone to, and the kind of injury you see which you go like, no, this is an abuse case. Okay. And then how will a child with emotional abuse as well present? And I'm gleaning all this from the objective itself. So if you've not gone through these, doctor, you've not finished this objective as well. You must know the causes of fussiness in a child. And which of the causes of fussiness in the child is an emergency? And which of the causes of fussiness in the child just needs reassurance? And what to ask on history when you're assessing a fussy sick child, as well as physical exam features of a sick child and investigations to request for a sick fussing child, as well as which children need a referral to a specialist, okay, and how to counsel on abuse prevention in children. So, doctors, I'll say it again. If you've not gone through all, if you've not gone through all these, please, then chances are that you've not reviewed this objective in total. If you've not gone through all these things I'm talking about, then chances are that you've not reviewed these objectives in total, right? So please don't just take a particular topic and go like, oh, I think I know this. No, the MCC is very specific. And that is why I have taken my time to break all of these things down for you. So what we're going to do is this. We're going to do a deep dive into one of these topics, approach the crying and fussy child. And I'm going to focus on colic. The reason why, and you will understand why I'm talking about colic, because I always say that common things are common. Okay. And if common things are common, you realize that colic is one of those things which is labeled as one of the common things you will see. In fact, about 8 to 40% of children will develop colic. So that means 4 out of every 10 children, about 8 to 4 out of every 10 children will develop, no, about 8 to 40 out of every 100 children will develop colic. So it is something you should be prepared for. You should not be surprised if you meet such a thing in your practice. You should not be surprised if you meet such a thing in your board exam, because it is common. Common things are common. So we're going to dive right in right now, and we're going to start the topic on the go. So let's start. And you realize that, as we've said, for us to get into these things, we always start with questions. So I need someone to read this first question for me, please. I need a volunteer to read a question. A volunteer, please raise your hand, start reading. Let's go. Because we have a lot of questions to deal with today. That is wrong. That is not even a question I should be asking you, especially because when I said based on the definition of crime, I should have reviewed this question. Let's jump this question. And the question is, it's straight up infantile colic, but rather let's go to this second question. Sorry about that. I should not even have answered this question. I should have taken that out. Mhm. Hey, Dr. Kante, please mute yourself. Okay, please. All right, let's continue. Beautiful. Please, doctors, type in your answers. Those on YouTube, those on Facebook, please type in your answers and let's go. Okay. Which of the following features would make colic less likely? So, in other words, red flag signs which makes colic not a likely diagnosis. Those on YouTube and those on Facebook, I'm waiting for your answers. It looks like those on Zoom are already putting out their answers already. Let me see the answers I'm getting on Zoom. Let me see the answers I'm getting on Zoom. So it looks like we have a competition between B and C. Some are going for C, some are also going for B. What about those on YouTube as well? Dr. Reza says he's going for C. And what is the correct answer? What is the correct answer? The correct answer is C. So, which of the following makes colic less likely? The crying episodes are associated with fever and poor feeding. Now, as before we go into the deep dive, you realize that in colic, there is no organic concern, right? So the crying episodes associated with fever and poor feeding is correct because fever and poor feeding suggest an underlying medical condition, not colic, which occurs in an otherwise healthy infant. So the first learning point we need to pick up as we going into this whole you know exam is that we need to understand that colic happens in otherwise healthy children. Now, for crying episodes which last more than 3 hours a day, that's a sin in colic. The baby is otherwise healthy and gaining weight appropriately. That's a sin in colic. The crying peaks in intensity around 6 weeks of age. That's a sin in colic. So, in this particular question, you are looking at the things which make colic not likely. And here, the answer will be fever and poor feeding. Okay, fever and poor feeding. Now, let's go to the next question. Let's go to the next question, doctors. Let's go to the next question. Mhm. Mm, good. So, I want to see your answers then. I want to see your answers. Doctors, are you going for A? Are you going for B? Are you going for C? What is your answer? What answer are you going to go for? Are you going to go for A, B, or C? And please, as we do this, make sure to like and subscribe to our YouTube channel as well, all right? So that we can keep growing with you and get this to as many doctors as possible and keep sharing our YouTube link as well. So, what is the correct answer? What is the correct answer? Can someone help us? What is the correct answer? I'm just going through it to see the answers which are coming up. What's the correct answer? What's the correct answer? I see a lot of people are going for B. B, educate, 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 educate. Sure. So you have a 3-week-old infant who presents with crying episodes lasting 2 to 3 hours daily, mostly in the late afternoons and in the evening. The parents are worried that their baby is experiencing pain. The physical exam is normal. Baby is gaining weight well. So it looks like this is a well baby. What's the next best step? And the next best step, a lot of people are going for B. Educate the parents about normal crying patterns and colic. So that is what is the correct answer is. Ordering a full blood count to rule out infection is incorrect because there's no sign of infection. The child doesn't have any fever. The child doesn't have any lethargy. Prescribing anti-reflux medication is incorrect because the infant has no symptoms which suggest acid reflux. Okay. And then the whole issue of hospitalizing the infant for further observation is incorrect because the child is well. Because the child is well. So that is that. Now let's go to the next point. And so we're going to do a deep dive into the introduction to colic itself. So I'm going to do that and then we will get the ball rolling. Deep dive into colic. Okay. So what you have to understand is that colic is a benign condition. That's the first thing because the objective was saying that we should know when to refer and when not to refer, when to give reassurance. So if you get a case like colic and you are going to refer to the specialist right away, that is wrong, right? So benign self-limited condition, which is characterized by excessive crying. Now, it is brought usually to the emergency room because it is distressing for the infant, it is distressing for the parents, it is distressing for the healthcare providers. In fact, the very first day I saw a patient with colic, I was like, okay, this is now I really understand. In fact, I needed to call a colleague to help me because it was quite distressing. And you are afraid as a clinician not to make a mistake, right? That this child, hey, maybe something wild is happening and I'm not paying attention to it. Okay. Usually the outcome is that colic resolves on its own. But the way the parents are handled during that episode at times can affect their view about healthcare and the care they are getting from the healthcare team. Okay, so usually you have to also understand the normal crying patterns. And I'm saying this because next year the exam is going to be MCQs only. Now, if you are dealing with a CDM, CDM is at times you have to bring out answers from your own mind, where you have to write some answers. If you are dealing with an MCQ, I'm just thinking if I was to be the one who sets MCQs, like what I set here, at times you really need some deep, specific knowledge. So it's not enough to say that, oh, I know that colic will resolve on its own, blah, blah, blah. Does milk affect colic? Does prematurity, is it a predisposing factor to whether the child will develop colic? What about children who are born in places which are close to the equator or children who are born in cold places? Which of them are likely to develop colic? So if you are going for an exam which is only MCQs, in as much as general knowledge is important, you've got to also have some specific knowledge. You know what I'm saying? And I'm going to ask you those kinds of questions as well because it's not enough. Somebody is, oh, the typical thing amongst us as IMGs, colic is 333. The child has been crying for more than 3 hours, for more than 3 weeks, for more than, that kind of thing. But beyond that, what are the nuances you need to know and you need to master so that you can be able to, pick up any nuanced statement? So that's why I'm bringing these things in. What is the normal crying pattern of an infant? Usually, infants cry more during the first 3 months of life, and that can be an MCQ question. That can be an easy MCQ question. Which of these periods are children likely to cry more? In the first month, in the sixth month, when they are 1 year, when they are 2 years, when they are 3 years, when they are 5 years, and then the unprepared candidate is sitting down, not knowing what to do, right? The average crying time is between 68 to 133 minutes a day in the first 3 months of life. By weeks 10 to 12 weeks, crying reduces to about 68 minutes per day, but it can vary. So the memory aid here I want you to understand is this. Think about C for crying. C is equal to crying peaks at critical first couple of months. So always remember that, children are likely to cry more in the first 3 months of life than as they grow. As they grow, they reduce the rate at which they cry. Now, in colic, they are crying for no apparent reason. Usually, and this is what I said is very common amongst us, this one everybody knows it. It lasts for more than 3 hours a day, for more than 3 days, more than or equal to 3 days a week in a healthy infant who is less than 3 months old. So that one, almost everyone who is preparing for MCQ1 knows these facts. But there are some other things you need to know. What are other ways colic can be presented? What are other names that colic can be presented? It can be presented as cry fast baby. So if you see that, it is still referring to colic anyway. It can also be referred to as excessive crying, unsettled infant behavior, or they even call it a period of purple crying. A period of purple crying. So if you see any of these, don't be so surprised. Now, what are the features of colic? They cry with no cause, no illness. So that is why the question was saying which of these makes the diagnosis of colic less likely. And usually you were expecting that, okay, if the child is well, then when I console the child should be able to accept the consolation, but they are inconsolable. And the memory aid again here is, remember, they cry more than or equal to 3 hours for more than or equal to 3 days a week. And usually that child is under 3 months. If you know this fact, that would be awesome. Now, there are two criteria, but I want us to focus on the Wessel's criteria. And of course, like no one is going to, quiz you. Like if I'm supposed to quiz you, I'm not going to quiz you. What is the Wessel's criteria? No, no, no. I'll rather put the Wessel's criteria in a question. So there are two criteria we use to classify children with colic, and I'm going to focus on only the Wessel's criteria. You can take your time to read about the room 4 criteria. Okay, the Wessel's criteria talks about the fact that the child is going to cry for more than or equal to 3 hours a day, on more than or equal to 3 days a week, and it persists for more than or equal to 3 weeks. And usually that child is normal. There's another criteria, we call it the room criteria, and the room criteria looks at the functional concerns of the child and how the child presents. But usually I like to teach my students about the Wessel's criteria. So what is the memory trick for colic? If you like, you can write this one down as well. Remember the word colic itself. So C stands for crying, crying for more than or equal to 3 hours a day. The O stands for on more than or equal to 3 days a week. L stands for longer than 3 weeks. I stands for in otherwise healthy infants under 3 months. And C stands for crying episodes are paroxysmal, louder, and inconsolable. I just wanted to get up, some acronym which will help you to remember colic. So crying for more than 3 hours a day, on more than or equal to 3 days a week, longer than 3 weeks, and the child is usually under 3 months. Always remember that the child cries more when they are less than 3 months, and as they grow, the intensity of the cry and the length of the cry decreases. Okay, so we're going to now go into the epidemiology of colic, and I'm going to quiz you as well. Let's do some quizzing and then let's see how we do. So let's go there as well. Let's go to the epidemiology of colic. Okay, so I need someone to read the case for us, please. Please go. Beautiful. Good. So doctors, please, everybody, type in your answers. Let's look at what's. That's why I'm saying that it's not enough to know. Okay, colic is three, three, three. No, no. If you are going, especially those who are going for the exam next year, you need to know some hard facts. So if you pick colic, what are associated with higher prevalence of colic in infants? Is it A, male gender, B, breastfeeding, C, prematurity, D, firstborn? See, if someone asks you this question, you go like, oh my goodness, what is going on here? You know? So doctors, please type in your answers. Is it A, is it B, or is it C? Looks like the Facebook and the YouTube team are going for C. Dr. Sarah went for B, rather. And then others are going for C. On Zoom as well, I see a lot of candidates going for C, C, C. Okay, good. So it looks like a lot of people are going for C, right? And it looks like C is the correct answer. So C is correct. So please, if you're on YouTube or Facebook or if you're on Zoom and you went for B or A or D, that is incorrect. The correct answer is C. Prematurity increases the prevalence of colic. And, there's a little split on that, but most of the time, that's what a lot of authorities believe. Some studies suggest colic may be more prevalent in preterm infants. Okay, the incorrect answers would be A, B, and D. And what were A, B, and D? So male gender does not increase the prevalence of colic. So the prevalence of colic is same in males as compared to females. Breastfeeding does not increase or decrease the prevalence of colic. And being firstborn does not increase the prevalence of colic. That characteristic which increases the prevalence of colic among all these four is premature birth. Now, next question, please. Who will take it for us, please? Please, who will take the question for us? Mm-hmm. Mm-hmm. Beautiful. I like that question. As I said, the MCQs, you need to know some hard facts. And especially next year, you're going to develop they're going to divide the 260 MCQs into two. You need to know hard facts. Don't just read on the surface. Okay. For CDM, you need broad knowledge. For MCQs, you need deep knowledge, right? So, which of the following geographic factors has been linked to a higher incidence of colic in infants? A. Colder climates. B. Rural areas. C. Proximity to the equator. And D. Low income countries. What's your answer, doctors? I'm waiting for the answers from Facebook, from YouTube, and from Zoom. So Dr. Reza went for D. What are Zoom candidates saying? This one, it looks like, you know, we are split. And I like that. People are going for D, low income countries. Low income countries. Are we sticking with D? Does anyone have any other answer? Who has read colic in textbooks? Dr. Fauzi went for D as well. Okay. What is the correct answer? What's the correct answer? What does up to date say? Colder climates. Colder climates. Colder climates. Colic appears to be more common in colder climates and areas further away from the equator. So the equator is like, those who are around sub-Saharan Africa, like Ghana, Nigeria, Togo, Benin, Cameroon, the equator. That is where there's a times some heat, right? Because of the closeness to the equator. Colic appears to be more common in colder climates. So if you pick if you pick children from Canada and you pick children from, say, Gambia or Ghana or La Cote d'Ivoire, you're expecting more children in Canada to have colic proportionally as compared to children who are close to the equator. So B and D do not show significant associations, and C is incorrect as colic is less common near the equator. And when we go to the deep dive in epidemiology of colic, we will also understand it. I want someone to also take this question for us. I want someone to take the question for us, please. Please take the question for us. Next question. Please take the question for us. Beautiful. This is the question where you rule out two of them and you go like, Dr. Brony, I have two more answers and I don't know what to do with them. That's what a lot of candidates will say. I don't know what to do. Dr. Brony, your marks are too tough. I have eliminated two and now I don't know what to do with the two more. Okay. So what's the correct answer? Those on YouTube and those on Facebook, please type in your answers. We are all with you. We are all studying together. Dr. Calvin says D. Okay. Let's go in and see what are the Zoom team also writing. Some are saying B, some are saying D. And you see, this is what I'm saying. So a lot of us will go like, oh, colic, easy topic. Oh, easy. I just need to reassure parents. Okay, if you meet colic in MCQs, how are you going to deal with it? That's the issue. How are you going to deal with it? So that's the problem. How are you going to deal with that? And what's the correct answer? The correct answer is B. Families with colicky infants report more family stress and dissatisfaction with their marital relationship. Because don't forget that health is not just the absence of disease. Health is everything which affects our psyche, our emotions, even spirituality, right? So colic has been associated with family stress and dissatisfaction. The incorrect answers are A, C, and D. There's no conclusive evidence to support their link with colic. So the correct answer is B, B, B. Okay, let's go to the next question. Please, who read for us, please? I need someone to read this question for us, please. Okay, okay. What's the correct answer? Please type in your answers. And that is what I like about these deep dive sessions, right? Because it helps us to really go deep into the topics and look at it from the MCQ1 perspective, MCCQE1 perspective, and the MCQ perspective. And I've decided to do this especially because of the changes which are coming up next year, where we're going to go to MCQs alone. So I'm like, you know what, this is the best time to start doing the right thing. Okay. So what's the answers we are getting? Looks like the YouTube guys and the Facebook guys are going for B, B, B. So let's see. What's the correct answer? What's the correct answer? What's the correct answer? The correct answer is B. Colic usually resolves by 6 months of age. Colic usually resolves by 6 months of age. Colic usually resolves by 6 months of age. Okay, good. So now let's go into a deep dive about it, and then we'll see or we'll get our learning points from the topic. Okay, doctors, please, I want your response. How is the class going for you today? Is it as you expected? Is it bringing out some of your weaknesses? Tell me something. I want to know so that we can be able to give you the best of service so far as this exam preparation is concerned. How is it going? Is it going well for you? Okay, good, awesome. So some are saying it's cool. Okay, good. So let's jump into let's do a deep dive into the epidemiology of colic. So I will say again, common things are common. Colic affects 8 to 40% of infants. Okay, 8 to 40% of infants. And remember that we said colic is more common in children in colder regions, and we are in Canada. Even though those in BC enjoy the weather so much, Canada is typically a cold country. So if there's one topic you need to learn and master for the MCQ1 exam, remember that colic is one of them. Okay, colic is one of them. What's the geographical influence on colic? Resource rich countries, more common. So you expect more colic in Canada, in US, in Switzerland, as compared to third world countries, right? It is more common in areas further from the equator. We looked at this in the question. Okay. There's no difference in colic prevalence between males and females, between breastfed children and formula fed children, between firstborns and lastborn. So whether the child is firstborn, middleborn, thirdborn, lastborn, no born, there's no difference. The one which the research is leaning towards a little bit as a risk factor for increased prevalence of colic is preterm infants. Preterm infants. Even that one is not a very strong one, but with all the options I gave you, preterm infants may have higher prevalence of colic. What are the family dynamics which worsen with colic? It puts a lot of marital stress. It puts a lot of parental stress. It breeds a lack of confidence in the parents because the parents don't know, okay, when can we actually tell when our child is really sick? Because the last time we took the child in, the doctor said, oh, they are fine. Why are you bringing them in? So it causes the parents to become, I don't know what to do again. The mother loses confidence, the father loses confidence, and they are afraid that maybe next time something may be happening to the kid and they will not know whether they should take the kid in or they should not take the kid in. Okay. And these factors influence how parents perceive and respond to crying. because it can take the parents either way. Some will go like, oh, whenever the kid is crying, it may be colic. But it could also be that there's something very serious wrong with the kid, and the mother does not pay attention, and then something bad happens to the kid, and then they start blaming themselves, right? So that is one thing. Okay, so now we're going to go into identifiable um risk factors for colic and some other things colic. So let's jump right in there and solve some questions about that as well. Okay. So questions to consider. I need someone to read this question for us, please. Please read a question for us. Mhm. Beautiful. Please type in your answers. Let's go. And I know the issue of abdominal distension there will confuse some people, but we'll take our time and later on in the answer section you'll realize why. So is it A? Is it B? Is it C? Or is it D? What is your correct answer? Are you going to go for pyloric stenosis, 8-week infant, episodes of crying, especially after feeds? Pay attention to that. Vomiting, failure to gain weight, irritable infant, mild dehydration, abdomen is distended, bowel sounds are diminished. Oh, okay. So it looks like there's not much confusion there anyway. So the class is broken. Some are going for A, some are going for C, some are going for A, and some are going for C. Okay. Now, those who are going for C, why did you go for C? And those who are going for A, why did you go for A? Can those who are going for C, can one of you unmute and talk to me why you went for C? And those who went for A, can one of you unmute and tell me why you went for A? Please. I don't want to just railroad this discussion. I want to hear some input. Why did you go for C? Why did you go for A? And it looks like some people even went for B. Why did you go for B? Please speak to me. I want to hear. So you mute yourself. Okay. Mm-hmm. Okay. 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 No, you said pyloric stenosis. You think 3 months. What has 3 months done? Okay, you think it's C. All right. So what about those who went for A? Hmm. Beautiful. Beautiful. And then Dr. Mariam also put something in there that in intestinal malrotation there is bilous vomiting as well. So what's the correct answer? The correct answer is A. And I know people go like, oh, the abdominal distension. Pyloric stenosis is suggested by projectile vomiting, poor weight gain, and the presence of distended abdomen with reduced bowel sound. So when you do what we call the succussion splash, you will hear it, right? Indicating a potential obstruction. Now, colic is wrong. Why? Because we said in colic, the child is normal, the child is not sick. This child is sick, this child is dehydrated, this child is vomiting after every feed, right? Colic is less likely as the child has abnormal growth and feeding difficulties. So, colic is not right. But what a lot of people are confusing is intestinal malrotation. In intestinal mole rotation, it can present similarly, but what will make intestinal mole rotation more likely in a board exam is that in intestinal mole rotation, it will also characterize the vomiting as bilous. And most of the time in intestinal mole rotation, like it will not be going on for a long time. The child is really sick. Like you have something like a volvulus happening. That child is really sick. It's not going to go on for days after days after days after days. By the time it's gone on for days after days after days after days, that child is probably dead, right? Cow's milk protein allergy might cause vomiting and crying, but it's typically associated with bloody stools or eczema. So, can someone take time with this information here? Now, break down colic, pyloric stenosis, intestinal mole rotation, and cow's milk protein allergy. Because this slide alone contains 4 diagnoses which you should master, right? So, can someone just pause me here and take over and using the information here, really tell the class how he or she is going to remember the concepts of pyloric stenosis, colic, intestinal mole rotation, and cow's milk allergy? Can someone do that? Please go. Please go. Please go. I like your confidence. Go. Yeah. Hmm. Beautiful. Hmm. Okay, sure. Uh-huh. Hmm. Beautiful. Hmm. 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 Okay. No, no, bloody stools or eczema. Okay, beautiful. 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 I like that. So for diagnosis that candidates usually miss because there are some nuances they cannot pick up. Cow's milk allergy, intestinal mole rotation, pyloric stenosis, and colic. So, doctors, tonight, somebody raise the hand. Please ask your question. Dr. Iram Zainab. Malrotation and volvulus. Volvulus is a subset of malrotation, right? Volvulus is, it's, yeah, because volvulus is a rotation on like the large intestine, and it presents with that horseshoe presentation, but it's same thing. Malrotation, similar. Mhm, mhm. Okay. So let's move on. Next question. I really like the contribution in the class. I want someone to take this question for us, please. Mhm. Beautiful. You said you are prepared for colic. Okay, let's see the answers. Those on YouTube and Facebook, what are your answers? Dr. Evelyn Valade says C. Dr. Fauzi says C. Now let me come to the Zoom team. Um, where are the answers? Looks like a lot of people are going for C. 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 Looks like a lot of people are going for C. Okay. So 4 week infant presents with excessive crying, especially after feeding. Baby is formula fed, and parents report no projectile vomiting or diarrhea. Physical exam is normal and growth is within normal limits. What would be the next best step in management? Start treatment for gastric esophageal reflux disease, change the formula to soy-based formula, reassure the parents and offer supportive management for colic, refer for further evaluation and imaging studies. And the correct answer is C. Reassure the parents and offer supportive management for colic. The infant's presentation is consistent with colic. It is characterized by excessive crying with normal physical exam and growth. Supportive management and reassurance are key. Remember that, because the objective was saying, when are you going to reassure parents? When are you going to refer them, right? GERD may cause crying after feeding, but will typically be accompanied by regurgitation. So that's word you are looking for. That is the word you are looking for. Okay, regurgitation. What do you say? Sorry, GERD. Yeah. Oh, heartburn. Okay, okay, okay. Yeah, but a baby can tell you I have heartburn. Right? Oh, Doctor Idris, I have heartburn. I have so regurgitation or other signs like failure to thrive. Right. Soy-based formula would only be considered if there are signs of cow's milk protein intolerance. And imaging is not indicated unless there are red flags like poor growth or abnormal examination findings. Okay, next question, doctors. Let's go. Next question. Next question, please. Mhm. Okay, beautiful. Mhm, mhm. Beautiful. We've already discussed this question briefly. So now you have the tools. You have the tools. You have the tools to tell me. You have the tools to tell me what the correct answer is. It looks like people are going for D, 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 D. What are the people on Facebook and YouTube telling me? What are they telling me? Are you going to go for A? Are you going to go for B? Are you going to go for C? Or are you going to go for D? What are they telling me? Okay. Looks like the answer is D. Remember? So who can now tell me why did we go for volvulus? Even before I go into the explanation. What's changed? Why didn't you go for, if I'd put biliary colic there? Is it biliary colic? Pyloric stenosis, sorry. Would you have gone for that? If yes, why? If no, why not? And why is it volvulus for you this time? Mm-hmm, mm-hmm. Beautiful, beautiful, beautiful. That is it. Mm-hmm. Sure. Usually, intussusception occurs when you are trying to wean off the child from breastfeeding, right? Or when you start introducing other feeds, because it causes the lead there is usually the enlarged Peyer's patches, which is like the lymph nodes around the intestine, and they catch on it, and then it forms the intussusceptum and the intussuscipients, right? So usually when you are introducing other feeds to the children. Now, I have a question before we even move on. This is away from children. If you have a 70-year-old male who presents with symptoms similar to intussusception, what comes into your mind? What is the possible cause of that intussusception? Cancer. Hmm. But it could be a lead. Always when you're thinking about intussusception, think about a lead, and it could be like a colon cancer, like a colon tumor. right? Which is leading to that, which is leading as a point, the lead point. Because remember, interoception is like this, like the intestine is like that, right? And then one involves into the other. So most of the time, the lead is the tumor in the wall of the colon, and then as the 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 colon moves up and down during peristaltic movement, and then it rolls on each other, and then it gets into it. That's what the problem comes in, right? So when you see intussusception in an elderly man, think about possible tumor. It could be a benign tumor, but in an elderly man who is probably more than 70 years, chances are that something bad is going on, right? So I just wanted to throw that in. So what is the correct answer? The correct answer is volvulus. Volvulus presents with bilous vomiting, like we said, right? Abdominal distension and dehydration. Remember that pyloric stenosis would also present with um, dehydration, failure to thrive, um, vomiting after meals. But volvulus is more acute. Pyloric stenosis would have gone on for some time. Volvulus, that kid will be sick because the intestine is turning on itself. That kid may even be in metabolic acidosis, right? Intussusception typically presents with intermittent crying, but bloody stools are more characteristic. Okay, and colic is unlikely with vomiting, abdominal distension. So have another question, because we talked about milk protein allergy, and we also said that will also present with bloody stool. So who can differentiate between intussusception and milk protein allergy, for which both of them will may have some bloody stool, but how will you tell the difference? Can someone help me? Okay, milk protein allergy. And what condition did we say children with milk protein allergy have associations with? Eczema. Beautiful. Let's move on. Next question. Next question. Next question. Let's move on. People are picking it up, and I'm very glad about it. Next question. Let's go, please. Okay. So, what's our answer? Hello, can you see me? Hello, doctors, can you see me? Oh, what's happening here? I don't know. Can you see me? Oh, can you see me or no? Hmm. You can't see me, hey? Hmm. I don't know what is going on. Okay, let me um just maybe what I'll do is can you see me, Dr. Irene? Let me just stop the streaming and then we start again. Okay, so just use the same link and join me. Is that okay, please? Um, I don't know.